So I'm going to be giving a grand rounds presentation today on thromboembolic disease and total hip replacement and total knee replacement. And I'm going to talk about an overview and prophylaxis strategies. I'm Jeff Westrich from the Hospital for Special Surgery in New York City. The outline of the lecture is going to be an overview of thromboembolism. Then we're going to go into the American College of Chest Physician Guidelines and the American Academy of Orthopedic Surgeon Guidelines. I'm going to talk about mechanical prophylaxis and how we use that at Hospital for Special Surgery. And then I'm going to go into the specifics of the Hospital for Special Surgery approach with multimodal prophylaxis. The prevalence of deep venous thrombosis in orthopedic surgery without any prophylaxis historically has been quite high. And in knee replacement, it's been almost 60%, with proximal thrombosis up to 36%. And in hip replacement up to 84%, with proximal thrombosis 20%. What's unique about hip replacement compared to knee replacement is the development of isolated proximal thrombosis that can occur. When we look at the pathogenesis of DVT, there's a very delicate balance between thrombogenesis and fibrinolysis. That is, the formation of a clot and the breaking down of a clot. If we go to Virchow's classic triad that he described in 1846, there's three arms of this triad: venous stasis, hypercoagulability, and intimal injury. And I'd like to relate all of these to joint replacement. So venous stasis clearly occurs when we're doing hip and knee replacement by the intraoperative use of a tourniquet in knee replacement, post-operative immobility, patients that are obese, have varicose veins, congestive heart failure, and kinking of the common femoral vein. Hypercoagulability occurs by activation of clotting factors and changes in platelet activity. And intimal injury can occur with kinking in the common femoral vein, dislocation of a joint, and thromboplastin release. This is an example of a cadaveric dissection during a hip replacement where you can see on the lower panel complete kinking of the common femoral vein and the common femoral artery. And this occurs whether it's the posterior approach or the anterior approach in total hip replacement. The American College of Chest Physicians were the first ones to come out with guidelines for the prevention of thromboembolism for total hip and total knee replacement. Unfortunately, many of the orthopedic surgeons and the orthopedic surgery community were taken back by these guidelines because they recommended very potent anticoagulation. They recommended warfarin, low molecular weight heparin, and fondoparinox, but downplayed aspirin, intermittent pneumatic compression, and adjusted dose heparin. Those particular guidelines also ignored issues pertaining to bleeding with regard to using potent anticoagulation, which was quite a concern among many orthopedic surgeons. So we now have orthopedic surgery guidelines from our own American Academy of Orthopedic Surgeons. And what they did was they paid a lot more attention to bleeding issues, which were essentially ignored by the American College of Chest Physicians. And they also determined a risk stratification model. And what they found was they divided these patients into four different groups: patients at standard risk for major bleeding and pulmonary embolism. And those patients could in fact have aspirin, low molecular weight heparin, synthetic pentasaccharides, and warfarin. So the surgeon got to make the appropriate decision. Patients at elevated risk of pulmonary embolism could have low molecular weight heparin, synthetic pentasaccharides, and warfarin. So there, if they were at elevated risk of pulmonary embolism, aspirin was eliminated as a choice. Patients that were at elevated risk of major bleeding had aspirin, warfarin, or no prophylaxis, and there, in those particular cases, the more potent anticoagulants were eliminated. And then patients at elevated risk for pulmonary embolism and major bleeding had aspirin, warfarin, or nothing. And again, potent anticoagulation was ignored. Recommendation 1.1, all patients should be assessed preoperatively for elevated risk of pulmonary embolism. Recommendation 1.2, all patients should be assessed preoperatively for elevated risk of major bleeding. Two very important points. Recommendation 1.3, patients with known contraindications to anticoagulation should be considered for a vena cava filter. Recommendation 2.1, patients should be considered for intraoperative and or immediate postoperative mechanical prophylaxis. So basically all patients should have mechanical prophylaxis based on the current orthopedic guidelines. Recommendation 2.2, in consultation with an anesthesiologist, patients should be considered for regional anesthesia. It's been shown that regional anesthesia has much lower rates of deep venous thrombosis and pulmonary embolism than general anesthesia. Additional recommendations, 3.1, post-operatively, patients should be considered for continued mechanical prophylaxis until discharge to home. So all patients should have a mechanical compression device according to the AOS guidelines. Post-operatively, patients should be mobilized as soon as feasible to the full extent of medical safety and comfort. Early mobilization. Recommendation 3.4, routine screening for deep venous thrombosis and pulmonary embolism post-operatively in asymptomatic patients is not recommended. So routine use of ultrasounds, venograms is definitely not recommended. Recommendation 4.1, patients should be encouraged to progressively increase mobility after discharge to home. And recommendation 4.2, patients should be educated about the common symptoms of deep venous thrombosis and pulmonary embolism. With regard to thromboembolic disease prophylaxis, we believe in a multifactorial approach. This includes preoperative prophylaxis, which is really an assessment of risk factors, intraoperative prophylaxis, and postoperative prophylaxis. What are risk factors for thromboembolic disease? Well, the most important thing is probably patients with a history of thromboembolic disease, a family history of thromboembolic disease. It's very important in the office that surgeons preoperatively assess patients' risk factors to do a risk stratification for what they're going to do postoperatively. Intraoperative prophylaxis is next. This includes the anesthetic technique with a regional anesthetic compared to a general anesthetic. Regional anesthesia has been shown to have decreased deep venous thrombosis rates and also less blood loss. In addition, expeditious surgery, less than 70 minutes in one study, was also noted to have a lower incidence of deep venous thrombosis. What about postoperative prophylaxis? Well, postoperative prophylaxis can be pharmacological prophylaxis with aspirin, warfarin, low molecular weight heparin, and then mechanical devices, such as calf compression devices and foot pumps, as you see here. Pharmacological prophylaxis that's currently existing includes parenteral heparin, such as low molecular weight heparin, oral warfarin, Coumadin, acetylsalicylic acid, aspirin, and fondoparanox, Rixtra. In development, there's some newer medications, oral heparins, and direct thrombin inhibitors of factor 2A, 9A, and 10A. The choice of prophylaxis is truly a balancing act. The more potent anticoagulants will decrease the clot burden, but obviously increase the risk of bleeding. The corollary to that is that a less potent anticoagulant, for example aspirin, may have a greater incidence of clot, but a lower incidence of bleeding. And again, we have to find the right balance in our choice of prophylactic agents. I'd like to now discuss mechanical compression devices. At Hospital for Special Surgery, we've done a lot of research in mechanical compression devices. These devices work by decreasing venous stasis and accelerating venous emptying, and may also have a fibrinolytic effect. They clearly have proven efficacy in multiple surgical subspecialties. They have a minimal complication rate and are not associated with bleeding complications that you can see with potent anticoagulation. Mechanical compression devices come in all different shapes and sizes. There are different types of devices, such as foot pumps, and calf thigh pumps. There are also different types of compression that they utilize. There's standard compression, sequential compression, and newer rapid inflation types of devices. I became interested in mechanical compression devices many years ago, and we have an article entitled Prophylaxis Against Deep Venous Thrombosis After Total Knee Arthroplasty that we published in the Journal of Bone and Joint Surgery in 1996. This study involved a randomized prospective assessment of a pneumatic compression device with foot pump technology compared to aspirin alone. And what we found was a reduction from aspirin alone of 59% incidence of deep venous thrombosis to using a foot pump of 27%. which was quite significant. I then pursued this technology and wanted to assess the difference in different types of pneumatic compression devices. Based on our experience with our previous study in pneumatic compression, I became interested in looking at the venous hemodynamics of pneumatic compression devices and wanted to assess if there are differences between these devices. And what we did was we looked at the venous hemodynamics in a cohort of patients after total knee replacement and then also in total hip replacement. And these were very specific studies which are called crossover studies, where what we did was we put various pneumatic compression devices on each patient. And what we did was measure the increase in peak venous velocity above and below the common saphenous vein and look at the increase in peak venous velocity from the baseline of each of the different pneumatic compression devices. In between each device, the patient's hemodynamics went back down to a baseline level. We used a computer-generated randomization table for the order of the devices in every patient. This first slide is the study that I published after total knee replacement patients, and the second slide is the study that we published after total hip replacement patients. But basically what we did was in the recovery room after surgery, put on a pneumatic compression device and look at the increase in peak venous velocity. And this is an example of the waveform that we would see using an ultrasound device. In the total knee replacement study, this is an example of what we found when we pooled our data from the different pneumatic compression devices. And what you can see all the way on the left at the bottom is the foot pump technology had a 29% increase in peak venous velocity over the baseline and a 65% increase in peak venous velocity over the baseline with the two different devices that you can see in the legend on the right. Using the same foot pump technology and adding a calf sleeve increased the peak venous velocity to 221%. Using an impulse calf compression device with the VenaFlow, there was a 300% increase in peak venous velocity. The traditional devices that we had used at our hospital were slow squeeze devices, and you can see in the middle the 87% increase in peak venous velocity with the Flowtron. The Kendall sequential compression device had a 116% increase in peak venous velocity, and the Jobst device, 263% increase in peak venous velocity. Asking the patient to actively dorsiflex and plantar flex their foot had a 175% increase in peak venous velocity. The problem is that this couldn't be sustained over time. Also, when patients are anesthetized postoperatively, when they have a regional anesthesia that's still working in the recovery room, they're unable to actively dorsiflex and plantar flex their foot. But you could see that from this study, the newest technology with impulse pneumatic compression with the VenaFlow had the greatest increase in peak venous velocity of over 300%. With the hemodynamic study, we took the device that had the greatest increase in peak venous velocity, which was the VenaFlow device, and we did a head-to-head comparison with VenaFlow and Lovenox versus VenaFlow and aspirin to see if adding a potent anticoagulant with mechanical compression made a difference. This was a randomized prospective study. We published this in Journal of Arthroplasty in 2006. This particular study took knee replacement patients and randomized them to receive VenaFlow plus low molecular weight heparin, 30 milligrams twice a day, or VenaFlow with aspirin, 325 milligrams twice a day. And what we found was no statistically significant difference adding the low molecular weight heparin compared to the aspirin. The DVT rate was approximately 14% with the group utilizing the VenaFlow and low molecular weight heparin and 17.8% in the group utilizing VenaFlow plus aspirin, and this was not statistically significant. If you look at multiple studies that have compared deep venous thrombosis rates in knee replacement patients, the VenaFlow study that I just alluded to that we did at Hospital for Special Surgery overall had an incidence of DVT of 15.9%. The previous study that we did at HSS with the foot pump technology, using the plexipulse was 27%. So we significantly improved the DVT rate using a higher flow pneumatic compression device that pumps the calf as opposed to just pumping the foot. When low molecular weight heparin was used alone, the incidence of DVT in knee replacement was 38% in a study by Bob Fitzgerald, warfarin 55%, and a historical study from our hospital, aspirin alone, the DVT rate was 67%. So we feel we've come a very long way in prophylaxis for thromboembolic disease using a high-flow pneumatic compression device with VenaFlow. I did a similar randomized prospective study looking at VenaFlow and in total hip replacement patients, and we're using magnetic resonance venography to screen the pelvis for clots. We also were able to screen proximal clots in the leg. What we found was the VenaFlow mechanical compression device lowered the incidence of proximal thrombosis, again found by magnetic resonance venography, from 22% in the control group to only 8% with the VenaFlow device, so at a substantial reduction in incidence of deep venous thrombosis. And this was a study that we published in Journal of Bone and Joint Surgery. Another nice study was published by Paul Lekevich in the Journal of Bone and Joint Surgery in 2004. And this was a comparative study looking at two different mechanical compression devices to see if there were differences in the different kinds of mechanical compression technology. A high-flow device, such as the VenaFlow, with a standard sequential compression device, the Kendall device. He had 423 patients and 472 knee replacements. And in a head-to-head comparison, he looked at the DVT rates by ultrasound and found 6.9% incidence of thrombosis with the VenaFlow, but a 15% incidence of deep venous thrombosis with the Kendall device. Both this study and the previous studies that I showed from Hospital for Special Surgery clearly show that not all mechanical compression devices are the same. And the same way that there are improvements in the pharmaceutical industry with drugs, there are improvements in mechanical compression devices. And I think that's probably one of the most important points from my lecture today. We've demonstrated that improvement in the technology with impulse compression and newer technology has a much lower incidence of deep venous thrombosis than using standard sequential compression technology. If you look at a meta-analysis that I did that was published in the Journal of Bone and Joint Surgery back in 2000, we looked at all the different kinds of prophylaxis that could be used. And if you look in a meta-analysis and combine aspirin, warfarin, low molecular weight heparin, and pneumatic compression, and then assess the DVT rates, you can see that aspirin alone clearly has the highest rate of deep venous thrombosis, 53%. Warfarin alone, 45%, low molecular weight heparin 29%, but mechanical compression 17%. So clearly using a mechanical compression device is important in prophylaxis for all knee replacement patients. In a meta-analysis looking at hip replacement patients, it was found that low molecular weight heparin and warfarin and mechanical compression all had approximately the same incidence of deep venous thrombosis, but clearly the bleeding with the more potent anticoagulants was very significant compared to mechanical compression in the meta-analysis where there wasn't bleeding. I'm commonly asked for the Hospital for Special Surgery recommendations, and so now what I'd like to do is share with you the thromboembolic disease prophylaxis at Hospital for Special Surgery. First and foremost, we believe in a multifactorial approach. And that is preoperative prophylaxis, intraoperative prophylaxis, and postoperative prophylaxis. For preoperative prophylaxis, what I mean by that is an assessment of risk factors. And so every patient that comes in the office, I'm thinking about risk stratifying those patients. So I want to know, do they have an increased risk for deep venous thrombosis, pulmonary embolism, i.e. do they have any underlying problem that would put them at greater risk? And secondly, do they have any increased risk for bleeding? And I think those are very important things to ascertain from the patient before you even embark on a surgical procedure. The second is intraoperative prophylaxis. And intraoperative prophylaxis, for us, is a regional anesthesia. And in hip replacement patients, we actually lower the mean arterial pressure, and we believe in doing this because we increase the blood flow by adding epinephrine, and this increases the blood flow to the limbs but lowers the incidence of deep venous thrombosis. Post-operative prophylaxis is crucial. Mechanical compression devices are essential. We've studied many different mechanical compression devices that are out there, and we use Venaflow because it has the greatest increase in peak venous velocity compared to all the other devices that we studied, and has also been shown in a head-to-head comparison with a sequential compression device that to cut the DVT rate in half. So this newer technology we feel is very beneficial. The second part of post-operative prophylaxis is pharmacological prophylaxis. And again, we recommend following the AOS guidelines. And what this is basically risk stratification. And in low-risk patients, we will use a multimodal prophylaxis with aspirin. In higher-risk patients, we'll use a multimodal prophylaxis with either warfarin or, in rare cases, a low-molecular weight heparin. I think the future of thromboembolic disease is genetic risk factors. And it has been shown that genetic risk factors can be associated with hypercoagulable states and an increased risk of 3 to 20-fold. As you can see from this slide, there are many genetic risk factors that we are now discovering that can put patients at greater risk for the development of thromboembolism. Unfortunately, without testing these patients, we don't know who's at greater risk when they walk in the door. The future of thromboembolic disease prophylaxis, in my opinion, is going to be a genetic screening tool that once we have something like this would allow clinicians preoperatively to identify patients at increased risk without a prior history of such comorbidity. Prophylaxis could then be tailored to a patient's specific risk profile. What I mean by that is that we can then risk stratify patients based upon their genetic risk, and we can only use the more potent anticoagulants for patients that have genetic risk that put them at a much higher risk category. This way, we'd be able to avoid the complications associated with potent anticoagulation, such as bleeding, and also the increased cost of these medications, and only use them in specific circumstances where patients are at greater risk. In conclusion, thromboembolic disease prevention is essential in all orthopedic patients. The most important take-home message is the following. Use a Greenfield filter for patients who have contraindications to anticoagulation. Use regional anesthesia for all patients if possible. Use mechanical prophylaxis for all patients. The anticoagulation should be based upon the risk of bleeding, and avoid routine postoperative screening for deep venous thrombosis and pulmonary embolism. Also, what I think is very important is that surgeons and internists should make the decision about what type of prophylaxis should be used. And this includes both the type of mechanical compression device as well as the type of pharmacologic prophylaxis that's going to be utilized. One of the things that I've learned so far in my career is that choosing a mechanical compression device, for example, that is inexpensive but has a poor hemodynamic profile would not be helpful to the patient. And that the same way that there are differences in pharmacological prophylaxis, there are also differences in mechanical prophylaxis. Surgeons and clinicians should clearly look at the literature and try to determine what are the best choices that they should use for their patients. Thank you.